Thank you so much for the welcome and for being here in Rochester. You picked a particularly good day to show up in Minnesota's finest weather. It won't last long, so as mentioned, I'm the Dean of the Mayo School of Continuous Professional Development, but I'm also a practicing orthopedic surgery focusing on hand. And while I was sitting there, I was watching some of the slides rolling by, and I was astounded at how much I didn't know about differences based on gender, even with ACL injuries. And I deal with the hand, but as an orthopedic surgeon, I should know those things. And that brings me to the other thing I wanted to say before the formal introduction. About 6 months ago, I had a significant health crisis myself, had a close blow with death, but I'm fine now. But in the meantime, I've been told to unstress, so everything I do has to be passed through a very high-pass filter in the name of Evelyn, my wife. And this goes to committee assignments, talks, and everything. And I'm always a little nervous when I approach her about this. She's basically my agent. And when I told her about this opportunity, I was nervous. It was a Sunday afternoon. I was just in Arizona yesterday and just got back. We've got a full clinic in Orlando this coming week. And she not only said that it was perfectly fine for her for me to do this, but she wanted to know if she could attend this when I told her what the subject was, so it's clearly important. Thank you very much. On behalf of the Mayo Clinic and the Mayo Clinic of College of Medicine, I want to extend my personal welcome to this groundbreaking Sex and Gender Medical Education Summit. On this day, in these beautiful surroundings, I'm thrilled to see such broad representation of the medical education community. When I see the list of participants, literally from around the world, I'm proud to be standing here with you as you charge towards succeeding your mission. We each personally recognize that sex and gender are important. This is reflected at a high level by the National Institutes of Health Initiative and the growing effort of incorporating principles of individualized medicine into everyday healthcare provisions. Those that are in practice and education are pursuing this out of their own insight and passion. But we recognize that for a culture shift to occur, we need to incorporate this into educational curricula, but not as a standoff topic, truly integrating it throughout the formative education years and then reinforcing it beyond. Truly an integral part of lifelong learning. This symposium has been organized to provide resources and hopefully spark development of future resources to help embed sex and gender issues throughout the entirety of medical education. I can assure you that the school I represent, the Mayo School of Continuous Professional Development, is enthusiastically up for this challenge. I believe we are in an ideal environment for this to occur. Mayo Clinic just celebrated its sesquicentennial. As an orthopedic surgeon, that's really hard for me to say, so 150th year anniversary. And the founders, William Morrow Mayo and his two sons, they're in the left center panel there on the wall. Will and Charlie are his sons, set the stage and practiced the principles that we continue today as the Mayo model of care. Their vision is incorporated into every fiber of Mayo Clinic today. Will Mayo, the eldest of the two sons, at the 1910 commencement ceremony of the Rush Medical School, so eloquently stated, and I quote, "The best interest of the patient is the only interest to be considered, and in order that the sick may have the benefit of advancing knowledge, a union of forces is necessary." Think about that, a union of forces is necessary. This is exactly what you have formed, and what I challenge you to expand. The very organization of the Mayo Clinic reflects this with practice, education, and research, not only identified, but actually integrated with current care and future evolution. Mayo has invested heavily in strategic centers for individualized medicine, as well as the science of healthcare delivery and regenerative medicine. The College of Medicine includes the entire spectrum of medical education, including the medical school, school of health sciences, graduate school, graduate medical education, and continuous professional development. Additionally, we have Mayo Clinic proceedings, the medical library, state-of-the-art simulation centers, etc., and diversity and academic research efforts in education. And Mayo Medical School is launching campuses beyond Rochester with branches in Arizona and Florida to become the first national medical school. What an environment to catalyze your efforts. Mayo Clinic desires to be a leader with you in the arena of sex and gender education, and we are waiting with bated breath for the fruit of your labors to be shared. I wish you the very best for a most successful symposium, and I thank you for the opportunity to welcome you to Rochester. Thank you.
Well, good afternoon. I'm Phyllis Greenberg, I'm President and CEO of the Society of Women's Health Research. And I can't tell you what a pleasure it is for me to be here today with you. This has been something that I've been working towards for 25 years. And I hope that those of you who know me and the Society, and there are many of you in the audience who have worked with us in various capacities, I hope you will indulge me for a few moments while I tell the rest of you who we are and what we've done and how we've come to today. We were established in 1990 to focus attention on the inherent biases accorded to women through their lack of inclusion in medical research. We were the first and only organization to question if research done on young, white, healthy males could be applied to women. To say that we were met with derision would be an understatement. How do we have the audacity to question the way research had been historically conducted? Subsequently, we worked with Congress to have legislation passed in 1993, which mandated the inclusion of women and minorities in clinical trials, albeit only for phase 3. For the next few years, we held scientific advisory meetings throughout the country at various universities, focusing on conditions that differently, disproportionately, or exclusively affected women, excluding reproductive conditions, which at that time, as we all know, was the definition of women's health. In 1996, we submitted a proposal to the Institute of Medicine, asking them to validate sex differences research. And while that is a long story in and of itself, the result was an unequivocal yes, and I quote, "Every cell has a sex, and sex differences research needs to be conducted from womb to tomb." Apparently, some of the information presented in our science was actually used in the committee report, since there was little published research on sex differences at that time. We followed that with sex and gene expression meetings, focusing to a great extent on basic research, and out of that we established a scientific organization, the Organization for the Study of Sex Differences, and a basic science open access journal, The Biology of Sex Differences. To further advance research, we were also simultaneously holding interdisciplinary research networks on sex differences in the brain, metabolic issues, cardiovascular disease, musculoskeletal issues, and more recently on Alzheimer's disease, and neurological conditions and sleep. And future networks were going to be focusing on mental disorders, COPD, and pain. Our website, www.swhr.org, has a list of participants of all the networks, the researchers, the clinicians, and their accomplishments as a result of these collaborations. Also, I left some information, as those of you who have some information, the packet apparently we send them information on the society that I hope you will take a look at. So I'm sure you've been following the policy changes at the NIH, which would require researchers to balance male and female cells and animals in preclinical research. This change was a result of the Society's advocacy work with Congress. Also, our work with the FDA has resulted in getting a little technical here. In section, I don't know how many of you know, it's 907 of the DASHA, which places a priority on examining sub-demographic analysis in the approval of drugs, devices, and biologics. The FDA now has snapshots online detailing the demographics of the participants of recently approved therapies. These snapshots are supposed to demonstrate that much work needs to be done in determining clinical meaningfulness and relevance in subpopulations. In January, we're hosting a meeting in partnership with industry and CROs and other stakeholders to examine that question and address methods to achieve adequate demographic subgroup representation, appropriate subgroup analysis, and clinical relevance or meaningfulness. We're also actively working with members of Congress on the Research for All Act to codify the new policies of the NIH and working to get the same bill introduced in the Senate and that concept included in Senate Innovations the Healthier Americans Initiative. It's one thing to announce a policy change and another to see it through. 25 years later, it's thrilling to be attending a summit on how to translate what we know so far about sex and gender differences into medical curriculum so that our current and future healthcare providers know and understand the differences and incorporate them into their practices. This is truly a momentous occasion for me and for the Society for Women's Health Research. And while we are not done yet, and we have more work to do, we are finally seeing the light at the end of the tunnel. By the way, they're publishing a book which will go into great detail about the 25-year struggle to get us to this day, and also what some of the sex differences that we know and what we don't know and what we need to know. It's called The X Effect, the fight to personalized medicine for womankind. I hope you read it when it's published, hopefully in the next couple of months, and pass it on to your colleagues. So we know that it can take decades to translate innovations into clinical practice, but sex and gender differences are real and impact patients in so many different disease areas. We cannot wait for decades. Physicians take the oath to do no harm, and the knowledge of sex and gender differences research can help them uphold that motto. The new catchphrase of the day is precision medicine, and sex and gender differences are a critical component to achieving individualized care. Thank you again for attending this important conference. Thank you, Marjorie and Eliza and everybody at Virginia that worked to put this together. Thank you all for attending this important conference, and let's work together to deliver the best and most appropriate care to all. Thank you. Now, I'm honored to introduce Ann Bonham, Chief Scientific Officer at the Association of American Medical Colleges, AAMC. Dr. Bonham represents the AAMC nationally on a number of issues related to research, science, policy, administration, workforce development, education, and training. She serves on numerous panels, and I'm going to shorten this a little bit, including the Institute of Medicine Forum on Drug Discovery, Development, and Translation, the VA National Research Advisory Council, the IOM Committee to Review the NIH Clinical and Translational Science Award Program, and the Board of the Foundation for Biomedical Research. She served on a number of advisory boards, was awarded the 2012 Distinguished Alumni Award for Achievement from the University of Iowa College School of Medicine, and the 2010 Society for Executive Leadership in Academic Medicine International Award for Excellence. Dr. Bonham has been committed to diversity and gender equity in research and medicine throughout her career, and has received numerous teaching awards and has a track record of mentoring scientists and junior faculty and supporting the advancement of women in research. She also recently served on the NIH's advisory committee to the director of Working Group on Diversity in the Biomedical Research Workforce. She's authored blogs and spoken widely on the importance of the inclusion of women in clinical trials and the use of female cells in tissues in preclinical research. Dr. Bonham was an invited participant to the Georgetown Consensus Conference Work Group on sex as a biological variable, which produced a set of published recommendations to the NIH on this issue. As the AAMC's first female chief scientific officer, her activities continue to be grounded in the belief that all persons should benefit from the way we conduct, view, value, and participate in medical research. Prior to joining AAMC, Dr. Bonham served nearly 20 years on the faculty at the University of California at Davis School of Medicine, with an NIH-funded research program in cardiopulmonology and neurophysiology, and has served in various leadership roles. She has also chaired the governing board of the UC Davis CTSA and was a recipient of the Howard Hughes Men into Grad Training Award. There's more, but okay. I did kind of already. Please welcome Dr.
Well, thank you for that introduction that may be longer than what I have to say. It occurred to me, I was circulating around the posters, and it occurred to me that I feel almost inadequate to be giving any kind of comments or thinking to the people in this room, because just looking at the three posters, I mean, you're so far ahead in thinking about the science and thinking about education and in thinking about care and practice that I have to say I'm so impressed. The work that you're doing is not just here, though. I was recently at a leadership development conference for women at the Academic Alliance of Internal Medicine, and this notion of sex and gender-based differences was very well represented at that meeting. I'm going to St. Louis after this, and the whole focus there is on women leadership, and it's very important to them about recognizing sex and gender, sex as a biological variable. So the work that you're doing and have been doing, I think, has really taken hold in ways that you may not really appreciate. I want to call out a couple of posters, and that is this notion about Alzheimer's and amyloid deposition and progressing more rapidly in women, and what can be done about that, especially now that we have some imaging to correlate that with Chicago. It was very impressive. Also very impressive, but somewhat scary, was that women suffer more from a lot of medical interventions like angioplasty. The mortality is higher, as well as women effects from different drugs. I have to say, my own experience several years ago, I'm just going to blather on here, the heck with those slides. No. A few years ago, I taught residents and medical students cardiovascular medicine, so I knew about atrial fibrillation, talked about it, blah, 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 and then I got it. I had like 8, double espressos one day, and I had level atrial fibrillation, which of course I denied until after hours, and then called my colleagues, and of course they were thrilled because I was in cardiology, and they were thrilled that I waited till night to come. So they gave me, they treated me, blah, 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 and gave me a beta blocker, and the beta blocker they gave me was for a 70-pound kilo, and my heart rate went to 38. And I said, there's something not quite right with this. That because I feel like a heart rate of 38 is not something that's going to make me want to come back and see you guys, even though you're my colleagues. So I do have a little experience in that myself. Now, how do I run this by forward? There's an R on it, thank God. Although, okay, what do I do here?
The right arrow.
The right arrow, this right? This arrow? Thank you. Okay, so why am I here? No. Why are we thinking about this? Why are we thinking about this? And I think there are two reasons. One is the science is indisputable. I think you've shown that many, many times. I'm just going to move this up here so I can look closer. In these disorders and diseases and many more. So there's no question about the science. Though, to me, to my mind, this is about patient-centered, evidence-based care. Now, for me, patient-centered care is evidence-based. So when we think about this patient, this person, she does need your clinical judgment and an awareness of the best evidence. We also need to know where she comes, what's her family, environment, is she rural, what are the social terms of health, is she urban, what are the signaling pathways, the genetic pathways that control a lot of bodily function, and then what are the sex-based differences. Now, what's missing from this is making sure that the practitioners now and in the future understand this full spectrum of patient-centered, evidence-based care. And understanding gender and sex differences in medicine is clearly part of that. And what's the best way to do that? And that is in viewing this across medical education, undergraduate and graduate medical education. I was talking to somebody where the residents were saying, I'm not sure there's evidence that there are sex differences across the board in medicine. What do you guys do in your spare time up here? And this not only affects women's health, it also affects men's health. So I'll just take you looking back and looking forward a little bit. And I think this was in that landmark study where Bayer aspirin was shown to be effective in prevention of heart attacks in a little over 20,000 men. Of course, no women were included in that study. That did raise the issue a bit. And there was some good news in the NIH policy in 1993, the Revitalization Act, which actually called for inclusion of women and minorities in clinical research. It's strange that it took us to 1993, but they thought, well, we had to vote, so, you can't ask for everything. And then the IOM report that Phyllis referred to, I'm on a roll, all right. So MJ, whom I call Margie because I didn't really know, was kind of nervous about me coming, so I thought, I'll just let her rip. How's it going over there, MJ? So then there was the IOM report, and then there was a pause. In my view, not a lot of progress. But now, looking forward, we do have some movement. We have policies, new policies, as mentioned, and this was, I think, really, I want to give Janine Clayton a lot of credit for this because she worked and worked and worked inside the NIH and outside the NIH, and I think I was so happy to see this, and I know that she worked very hard to convince Francis that this was truly important. And then the FDA evaluation of sex-specific data in medical device clinical studies in 2014. I have to say that when Phyllis was telling me about her experience with the ANC 20 years ago, she said they were having none of this business about gender and sex-based medicine. And I'm happy to report that in 2014 we actually endorsed the consideration of sex as a biological variable in preclinical research. That was the first time, I think, that ANC had endorsed such a policy, and I'm very proud of that. I personally took this on and did some commentaries, went around the country a little bit talking about that on this blog. I said sex cells addressing sex differences in preclinical research, and then starting with cells, rethinking science as a place for women. So I've been mightily involved in this. Phyllis also mentioned the work by Catherine Sandberg and others who brought together a group to think about recommendations concerning the NIH to balance the sex of cells in animals in preclinical research. And I was proud enough to be a part of that discussion, and it was an excellent piece of work that they did. You all have done a lot of research, and there's been some research out there. I like this article in FAST, First Steps for Integrating Sex and Gender Consideration in Basic Biomedical Research, in the Schizophrenia Bulletin, incorporating sex as a variable in preclinical neuropsychiatric research. And I was proud to see that the University of California, Davis has a curriculum for psychiatry residents and thinking about this. And then this notion about how little we know about the effects of drugs in females, and I think this is a very strong work about, and it sort of underscores some of the work that you've already shown, that women behave differently and respond differently to different drugs. And finally, innovative models for integration of curriculum. I think MJ sent me this from Texas Tech, and I have to say, I was really impressed by this. I didn't have the whole thing, but I shared it with my colleagues, and I suggested that we should be doing some programming at the AAC around this, and I'm sure many of you have your programs, but I think the extent that you can share this is going to be really important. And finally, thinking about making this last, you all know that sometimes we have these spurts of activity. They last for maybe 5 years, and then they tend to go away. So thoughts on how to make this last. And first of it is acceptance of the science and acceptance of the need to integrate this across the medical education curriculum. And then there's reinforcing behaviors. It's certainly not the students, but it's also the faculty who are part and parcel of shaping the environment for the learners. And then I've learned since I've been in Washington, D.C., that really you have to have policies and practices. It's not enough just to fight the good fight, but you have to really have these policies, and then you have to work to implement the policies. So NJ asked me, well, what would you do? Well, I can tell you that anytime you're thinking about this at your own institution, it's important to engage in institutional leadership, and certainly Mayo has been behind this for a long time. But it really helps when the dean and the CEO comes out and says, we're going to be about this in our education, we're going to be about this in our care, and we're going to be about this about how we do our work. And the second one was, of course, we have these competencies, part and parcel of these competencies, thinking about the knowledge, practice-based performance, all of this is part and parcel of that. So I think making people aware of that. I was thinking that nationally the way that you can share across was to think about engaging an advisory board, not just of you, but to sort of spread this out. Sarah Fazio, Alliance for Academic Internal Medicine, the Women Leadership Program, she put together this program on her own. She's committed to this. She would be a good partner. Certainly, Janine Clayton, using her expertise, and as you know, she's made so many presentations on that, as well as looking to Canada. Certainly, Wendy Levinson is a big proponent of this, and I think if you could make this part and parcel of what she thinks about, that would be great. I think that forming partnerships, not just across your institutions, but for your academic societies, your Headstrong Women's Group. I think if you can get this on the program and on the agenda, on the minds of every society, the women's group, there's no way that this is not going to happen, because in many ways societies are instrumental in developing the curriculum for the residents. And finally, I hope that this becomes a sustainable scholarship for learners, for medical students, for residents, for graduate students, for postdocs. I think this is so important that not just embedding this in the education, but embedding this in the way we think about research. And certainly with precision medicine, I know that Kathy Hudson, who's leading this from the NIH, is very concerned that we integrate underrepresented groups in this precision medicine initiative. So we're not widening the disparities gap, but rather narrowing it. I think the same applies for women, and I think hanging on to that, embedding this in precision medicine is going to be key. Finally, I hope you submit to the National Medical Education Meeting. This is perfect. What you're doing is perfect. We have a lot of people come to those meetings. There's a lot of opportunity to network. Finally, I want to thank you for the opportunity to share a little bit with you. But mostly, I want to thank you for the work that you do, and to let you know for sure that AMC is very supportive of this work. And thank heavens, Phyllis, we made some strides in the past 2 or 3 decades to where now we're embracing evidence-based medicine, and including that sex is a biological variable, and also thinking about gender-based medicine, because it's not just the physiology, not just the genetics, it's not just the molecular signaling. It's also about the social determinants of health. And there's no question that this interplay of sex as a biological variable is important. But there is this interplay with gender differences, how we're perceived, how our behaviors are modified, the social determinants of health, the environment, and the poverty and the stress that women suffer. So to me, this is all about improving the health of women overall, from a biological perspective, from a neurophysiological perspective, from an emotional perspective, and from a societal perspective. I did have a slide in here about Donald Trump that but the people at the AMC said, and so, but I do have it on my iPhone. So after this, I'm happy to share. But, there's some things that I cannot do. So thank you again. And I'm sure I'll see you later. No. Does anyone have questions about Charlotte? Don't be afraid, because I know how to call on people and I know your name.
So as medical students who are currently going through this process and frustrated, I think, by the fact that, in AMO we learn a lot about women's medicine, but our medical schools are not doing such a great job. What do you think we can do as students to demand that we're taught?
Right. So thank you for that question. One thing that doesn't work very well is demanding. But you know what I would do, and I think it would be a mark of your success to do this, is to really have a conversation with your curriculum committee and talking about if you are going to provide the best care to your patients, both men and women, you have to understand this from an evidence-based medicine approach. And rather than saying, I think the last thing you want is a course, I think what you want to see is this integrated throughout. And the other thing that I would do is have guest speakers. I would have MJ come. I would have people come and talk about their research and their education and what they're doing. You can make that happen. I was at UC Davis, and the medical students had a health equity day. This very issue came up with them. They chaired the curriculum committee to the all-day session, and they were going to get together the next day and talk about how to integrate it. So I think you can do it. I don't think it's as big and far away as it feels. Call me and let me know how that goes. No, I'm serious. I get this advice and I'm going, well.
Okay, can you comment a little bit about how do we make it different from when we say sex and gender? Some people understand that to be only LGBT.
Only?
Well, it's almost as if they are reluctant to come to talk about this because they're from faith-based schools and feel that just the title kept them away. How do we get past that?
Do you mind repeating that question? I didn't quite get it.
I can take care of that because if you don't mind, because what we were surprised about here too is when people hear sex and gender, they equate it with gay, lesbian, transsexual health. They don't think of it in terms of male and female in the general population, that it influences all aspects of health and disease. So how can we bring that focus that we're really talking about a health disparity between men and women?
Right. So a couple of thoughts on that. One thing is that it's a little bit of a tricky issue because you don't want to look like you're being exclusive. You don't want to not include, because certainly LGBT have their own disparities and their own stigma and their own issues. So I think you really start with the science. As long as you're talking about sex as a biological variable, and you talk about Alzheimer's as different than women and men, we know that women present with angina and MI. We know that they present differently. We know that they present differently with depression. So I would start with not calling it a title. I would start with what's the problem. And the problem is men and women are different based on sex differences and the biological response to certain drugs. So that's kind of, and I would not ever say, I hope that you don't say, we are not LGBT, we are not women of color. I think what you want to focus on is sex as a biological variable. It's not going to get any easier with the trans community and how we define women.
Actually, the definition came from the Institute of Medicine before because there was so much confusion about what's sex and what's gender. And most of the research that has been done use the word gender because in Washington, at least in the old days, you could use the word sex now. That's fine. But, and of course, at the time, 25 years ago, there really wasn't this movement about, about gays and lesbians. Now, of course, the world has changed. So I think, that sort of sex and gender has sort of become the slogan, and I think it does include everybody. And actually, I mentioned that we're working on this on the clinical trials with minorities as well, and there's an effort also to have other genders or whatever in these trials. That's going to be difficult. It's difficult to get minorities, difficult to get women, to be more difficult. But we know that there are health differences, and that's part of the disparity.
I am the Curriculum Evaluation Committee Chair for the Medical College of Wisconsin.
Oh, yes.
And part of the reason the question that I have for you, and I'm commenting to the medical student, the women medical student, I'm pleased to see some men in this group. What I'm frustrated, and I wanted to comment to the students, is that how do you bring the men at the table? Because if you don't have the men at the table, you don't really have that representation. You don't have that perspective as well as the moving forward with what we see in the gender difference. So what do you do with that? I'm one of few, I think, in that group, but yet I'm one of the leaders. So what do you do, and how do you tell the students, the women students, to go and get the men and provide them with the research, provide them with the data, allow them to see that there is such difference in order to promote the future.
So from the student perspective, thank you for that. From the student perspective, you do what you can do, and your port is to demonstrate that you are most interested in providing the best care that you can possibly provide with evidence-based medicine. And sex is a biological variable that is part of evidence-based medicine. Over here, that's where I said my first thing is that this has to be at the top. This has to be the dean, the CEO have to get it, and they have to appreciate it. And the way to do that is that you bring in, there are men doing research in this area, so I think you bring them in. I mean, it always helps to bring in an outside expert to come and talk about that, and then to meet with the curriculum committee, meet with the chairs of medicine, meet with everybody. And I think that's one thing that you have to do. I don't think you should approach this as being radical. This is not like, we're renaming something. This is an understanding that sex of cells, sex of tissue, sex of people matter in both diagnosis, treatment, prevention, and sometimes responsibility.
And I think too, it's important to find faculty champions who will come to student AMWA meetings, for instance. And my student group, the AMWA group at UT Health Science Center in San Antonio, they've identified, shockingly, male faculty who are their champions, and they have male members of AMWA, and that's kind of been our inroad. It's just to have those men stand up and say, this is what we see in research. It is evidence-based, and it is important that we recognize these differences. So that's what has worked on my
And what's your name again?
Linda Solis.
Stand up, Dr. Solis. Everybody talk to her.
Thank you.
Hi, everybody. Hi, I'm Wendy Klein. I'm very honored to be on the planning committee. And it has been a great honor to introduce Dr. Noel Bairey Merz. She's a professor of medicine at Cedars-Sinai, where she holds the Women's Guild Endowed Chair in Women's Health, and is founder and director of the Barbara Streisand Women's Heart Center at Cedars-Sinai Medical Center, as well as director of the Preventive Cardiac Center. Trained at Harvard and UCSF, she's been the recipient of numerous well-deserved awards, is a tireless teacher and mentor, prolific author, and groundbreaking researcher in preventive cardiology and women's heart health, who's been continuously funded in heart research since she entered the field in 1987. Her contribution to the understanding of women's heart health and to the advancement of sex and gender-based medicine is profound. She's an innovator, a leader, a dedicated scientist, and we're honored to have her here with us to discuss sex and gender medicine, what it is and what it isn't.
Wendy and I were the dueling texters of would we get here on time, and we both got here. So many thanks, and wow, look at this great show. Thank you to our leaders, and thank you in particular to Mayo. I've not been in this room before. Where I went to medical school, there were no women on the walls. I like that, Virginia. Yeah. Well, it's very clear that it can be done. You just need effective leaders. Yeah. I'm going to speak on a number of things that we've just heard Dr. Bonham talk about, and I'm also going to share with you some hot off the press results that we will be presenting at the American Heart Association Scientific Sessions literally in about 2 weeks in Orlando. Here are my disclosures, and we just automatically disclose now. It's just a reflex. So I was asked to talk about what is sex and what is gender. Phyllis has already set us up a bit, but I'm going to give you case examples. They are going to be cardiology because I am a cardiologist, but my excuse for that is that heart disease remains the leading killer of women, despite our 20 years of work, so we still need to talk about it. So sex is the biological sexual differentiation. Women have ovaries, men have testes. Gender is the socio-cultural attributes of the biological sex. So, as an example, women have complex social networks and men have lives. This is all evidence-based. Please see me at the reception. I'm happy to give you the references. More terminology. Sex genotype, of course, is the XX chromosomal makeup, so XX dictates ovarian development of those stromal cells in utero. Sex phenotype is the genotypic expression given certain conditions. So premenopausal women have higher estrogen levels because they ovulate. Postmenopausal women have lower estrogen levels due to no ovulation. Both are XX genotype, but they differ in a phenotypic expression. All right, so let's just sort of, again, leading killer of women, let's talk about how sex and gender, or sex versus gender, might play out. So we did a lot of research in the 1980s about silent ischemia. How could heart disease be silent? How can it be the silent killer? Women have a greater perception measured by high-frequency non-auditory brain testing. Interestingly, gay men are intermediate between women who have higher perception and non-gay men who have lower perception, suggesting that this may be genotypic. And this is one of the lines of evidence, hard science, that is behind sort of the lesbian and gay community, that it is not a choice, that this is biology talking. Sex differences in pain. Women have lower thermal pain thresholds compared to men. They feel the pain sooner. Thresholds appear mediated by estrogen levels. So there are higher E2 levels that are associated with enhanced pain, suggesting that this may be phenotypic. And any pain physician or pain researcher will tell you, go into that waiting room, it's filled with younger to middle-aged women. And by the time they become older women, the big sex difference is pretty much gone. All right. What about gender differences? Women are more comfortable discussing feelings with friends and reporting symptoms to physicians. Possibly, the sociodemographers tell us, related to gender-related acculturation. Women take care of babies, women look at their own vaginas, they wipe penises and testicles, they know all about this stuff. They feel very comfortable talking about it. Gender differences in physician response to symptoms. Physicians, this is tested about every 10 years, it gets into the New England Journal every 10 years. Physicians are more likely to evaluate men compared to women and ethnic minority groups, possibly due to gender-related presentation styles and or cultural sexism and racism biases. So what are some consequences in then cardiovascular disease, the leading killer of women and men, oh, by the way, sex difference. So if women, for example, have those lower pain thresholds, and this was some of the work that we did in the PIMI study, they will perceive their chest pain sooner after the onset of true ischemia, MI, which is myocardial infarction. This will lead to longer estimated ischemia onset times in the emergency department, potentially leading to conclusions that you see in the literature all the time, that women delay seeking treatment, as well as making more women ineligible for that highly effective thrombolytic therapy. So these both would contribute and have been documented to contribute to these increased adverse outcomes that we see now in women with cardiovascular disease. What about a gender difference? Again, sociocultural. If women report generally more symptoms suggestive of chest pain because they feel very comfortable telling everybody about all their aches and pains, it will be less of an effective diagnostic tool, like radar. You hear blips all over the place. Doc is having trouble figuring out which one is real. This may be less specific for epicardial disease, which is the leading killer. This may lead physicians to have lack of confidence in testing, which they do in women, and it also suggests that chest pain symptoms may be difficult to optimize as a tool for investigators. All right, so that's our primer. That's sex and gender. Now we're going to talk a little bit about what we've done in cardiovascular disease, because again, we're sort of the poster child for what could be done. We've made some progress. So I'm going to talk about preamble, science, policy, and then our future. So we got started actually in the late 80s, and then it was really kicked off by these two women. And the one on the right, of course, you know, that's Barbara Streisand, and a benefactor of ours at the Cedars-Sinai Heart Institute. She has endowed our Women's Heart Center for research and education. And how come she looks like a guy? Because she's in that Yentl movie, which she directed, starred, and produced. And the deal was, of course, that in order to be educated in Eastern Europe at that time, you had to be a man. So she impersonated a man. So that's the Yentl syndrome, and that's the Yentl story. The gal on the left, you may or may not know, well, these are academics, you all know, that's Bernadine Healy. That was our first cardiology director of our National Institutes of Health, and also our first female director of the National Institutes of Health. Bernadine pushed that policy that Dr. Bonham just told us about, that if you were studying a disease, a clinical disease that impacted women and men, it was no longer acceptable just to study men, and that happened in the 1990s. Bernadine, of course, opined in the New England Journal in 1991 regarding this phenomenon, and it was, her editorial was called the Yentl Syndrome. In 1984, we had a new female majority. Women's mortality exceeded men's for the first time in recorded history. We recognized it. Bernadine wrote her editorial, and it was around the same time as the Yentl movie. People were starting to sort of think about why are so many women dying of heart disease? Maybe it's because we don't recognize them, because they don't look like men. Of course, it took a full 12 years for National Heart, Lung, and Blood and the American Heart Association to get going on this. If it had anything to do with erectile dysfunction or prostate, it would have gone a lot faster. Okay, so that's our preamble. Science was commissioned. So what happened between 97 and 2015? Well, here's where Janine, but people ahead of Janine, and I have to shout out Phyllis Greenberger and the Society for Women's Health Research really started this. And we owe a huge debt of gratitude. This is a newer cartoon, but when Phyllis says she was getting no traction, it's because we have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition, but medical research using women as subjects just never occurred to anyone. And whenever we would point this out, we were being alarmist, and we were being hysterical. Pretty classic. So National Heart, Lung, and Blood did commission the Y study. It was part of the big consortium that, again, Bernadine Healy had done huge financial set-asides for the Women's Health Initiative, and this was a small piece of it. And just an example of when you actually study women, and when you ask investigators to do sex-specific medicine, and you give them a little bit of money. We did not get much money. Here's one big example. When women have heart attacks, they erode the plaque. When men have heart attacks, they explode the plaque. Huge difference, and it's particularly relevant in our young to midlife women, who are the victims that are still dying more than the men. And no one would have thought of this without this kind of funding. We were also describing how women and men deposit fat, the fatty plaque, in their arteries. And in some ways, if you really thought about it, it's sort of similar to how women and men get fat when they get fat. When men get fat, what do they get? A beer belly, right? It's usually focal, visceral fat. You often don't see it until you turn them sideways, or you actually, look at their belt size. When women get fat, how do we get fat? All over. It's that lovely cellulite, right underneath the skin. Well, in fact, when you look with our intravascular ultrasound at how this fatty plaque is deposited in the artery wall, women actually aren't spared. They just put the garbage away better, and you don't see it on a traditional angiogram. Again, an amazing discovery. Again, we were in the New England Journal, JAMA in circulation. This was all like Christmas. Every day you had another package to open because women had never been studied. So what are the consequences of this, and what are the consequences of 20 years of continuous funding? It's very clear consistently in registries and observational cohorts, anything that is not mandated by guidelines or a randomized controlled trial,
Men continue to receive more treatment and women continue to die of ischemic heart disease. And how can that happen? Well, number one, women that look like men, so if they have this obstructive disease that shows up on the angiogram, like Barbara looks here like a man, they get treated. And you can see most of those patients are men, but there's a few women, it's about 20% women, and they get treated with their life-saving drugs, aspirin, beta blocker, ACE inhibitor, and statin. What happens when women look like women, when they have this microvascular dysfunction and the fatty plaque is embedded in the wall? As Barbara looks here with her husband, she looks like the woman that she is. And you can see there's not as many of those patients, but it actually is about 30% of all women, and it's about 10% of men. And remember, cardiovascular disease is the leading killer. So this is a lot. This is a lot more than, say, breast cancer. And it turns out they don't get treated. So you have all the little tombstones down there, mostly in that ischemic heart disease group. All right, so working into policy, because again, this is a consortium of folks here today that understand very clearly, we can do science till the cows come home. And until you actually get it put into policy and procedure, nothing is going to change. We've worked very hard over 20 years to embed our clinical practice guidelines with important evidence-based differences. What you can see is that 2 out of 8 are different. Okay, that's okay. And when we find they're the same, we say that's okay too. Thank goodness, we're doing a good job. And then here's what happens when you have guidelines. We talk about guidelines in our practice situation. Guidelines make good doctors great doctors, because guidelines help doctors think about it and make a better decision. It doesn't always have to be the right decision. They don't have to follow the guidelines. And so here's an example, not our research, published before and after guidelines implementation for ACS, which stands for acute coronary syndrome, which is an MI or a threatened MI. It's not particularly well legended here, so I've color-coded it. Following guideline implementation, mortality for women improves and the sex gap narrows. And why is that? Because even though they didn't look like men, the guidelines said treat them. And they got treated. And you can see the top 2 lines didn't really change. And why is that? Those are the male lines. They were already getting guidelines therapy. All right, so here's what's left. If we thought women and men should be doing the same in cardiovascular disease, there's your sex gap. We might hypothesize that women should do better, because women live longer. But if we could just even close this gap, we'd be pretty happy. So here's what's happened after 20 years of evidence-based and guideline work. We actually have reduced cardiovascular disease in women. This is observational. It's not a randomized controlled trial. It could be true, and unrelated. But we think we're probably doing something right. And I'm going to now move. So here are, I'm going to give you some fodder. I heard we've got a lot of deans here at medical school. So I'm going to give you some survey data that I find very interesting and may help you understand physician education. These first are community education. We're also presenting this at the American Heart. The AHA has clearly demonstrated that awareness has stalled. So our community, our women and our men that care about them are stuck now. 1 out of 2 knows that cardiovascular disease is the leading killer. We continue, because of this Yentl syndrome, because so many women don't look like men, they do not meet entry criteria for male pattern clinical trials. So here is the sad, sad reality, and why we have more women dying, and why we don't really know how to treat them, because they have a different phenotype, and so they don't get into the trial, and they never get tested. Perseverates knowledge gaps which adversely impact women. This is a Virginia Miller slide that she shared with me out of Science. This is, why Janine Clayton and Francis Collins put into place that policy. I mean, this is embarrassing. And I remember going on a site visit with Wendy Klein years ago to a manufacturer of a hormone therapy, and they were showing me these aortic rings, and I said, gosh, do you know if that was a female animal or a male animal? It's hormone replacement therapy. He didn't know.
And then here's, we really have to work on journal editors because we continue to allow the publication without it being sex stratified. And with so much of the digital publishing now, I just submitted a big clinical trial, and half of it's online, right? So it's not a page count issue. There's no reason they shouldn't require this data. All right, so here's the future, and I'm going to show you some of this. So here's what we're working at in our center, the Barbara Streisand Women's Heart Center, as well as colleagues and partners in this consortium here. So science, we're talking about advocacy and philanthropy. Philanthropy has made a big difference. For us, there are like-minded women out there that want to make a difference, and I would not hesitate to ask them in your community. They don't know your need until you ask them. Policy, research, and publication, guidelines, as I've shared with you, and then education, and I'm going to focus on that now. This is the Sex and Gender Summit, and let me share with you some of the work that we did. So when Barbara Streisand was fundraising for us, we went over. The train had left the station. We had a few extra $1 million. So we decided, what should we do with this? And she and Ron Perlman decided that they would start a Women's Heart Alliance that would work with all of the other groups in this space to help us understand the sex and gender differences in cardiovascular disease. So it's multi-pronged. Here's a case example and why this Women's Heart Alliance exists and why it is not redundant to the American Heart Association or the Society for Women's Health Research or the OSSD. Here's a case example. I have an editorial coming out in JACC, which is one of our big cardiovascular journals. I was asked to write this editorial because of the Virgo trial. So the Virgo is a large multi-center observational registry of young, under the age of 50, acute myocardial infarction matched to young men, 2 to 1, 2 women to 1 man. To understand this, it's a 4-fold increase. If you're a young woman under the age of 50, you are 4 times more likely to die of that heart attack than a young man. And that is our one group that continues to go up in terms of mortality. So this was commissioned appropriately by National Heart, Lung, and Blood. So here's the JACC manuscript. It identified that these young women, compared to the age and otherwise matched young men, were more likely to be diabetic. Well, that makes sense, and that's by a prescription of diabetic meds. Diabetes is a higher risk factor. It's one of our important sex differences in cardiovascular disease. It's a much bigger risk factor for women than it is for men. The women are less dyslipidemic, defined by a treatment of statin. You're already sort of suspicious about that. They're probably not really less dyslipidemic. They're just not getting treated. They are more overweight, and this was cataloged by physician advisement to lose weight, okay? But when they're actually weighed, they're less overweight compared to the men. So here's my JACC editorial, and I contrast the sex differences. So there's a sex difference, which diabetes is a more potent risk factor, but there's a gender difference. And this is that women are more objectified in society, and women are much more likely to be told they're fat, and they're much less likely to be given effective therapy, which would be a statin, right? And this is gender in action. And I put, when I submitted my editorial, I had this cartoon as figure 1, and they wouldn't publish it. They wouldn't publish it. And they said that the readers of JACC would be too upset. And I said, I think young women dying of heart attacks is kind of more important than your readers being upset. All right, but I caved. All right, a few more. Advocacy. This is what we're doing, supported by the National Institutes of Health. You kind of know this. I think Dr. Bonham already went through this. We took a big hit when the Centers of Excellence were defunded under a prior presidential time. And we do have the National Institutes of Minority Health, although there are currently no plans for a women's or gender institute, unlike Canada. So you could lobby for this. This is important stuff. And then here's our most recent policy. Okay, here's some of the stuff that the Society for Women's Health Research is doing. We've had 2 primers. This one is just being submitted as we speak. The previous one was a basic science primer. It's published in our journal, The Biology of Sex Differences. And it is a go-to tool for any investigator that wants to incorporate sex and gender into their basic and their clinical studies. And it's all right here, and you don't need to read these at this time, but you need to know that they exist. And it's not about education per se, but it's education for investigators. And particularly as policy starts to require this, and editors start to require this for publication, which I anticipate will be happening, then people need these tutorials, and they need tools to be able to make their models fit. All right, so here's where we are. Our Women's Heart Alliance came up with logos. It's called Fight the Lady Killer. It is a celebrity lead national, that is Barbara Streisand, as well as local campaigns. It is three-pronged: awareness to destigmatize counter stereotypes with facts. Believe it or not, body weight is not a risk factor for cardiovascular disease, and everybody always finds that shocking. But look up any of the risk scores, it's not there. And why do you think it's not there? Because there's no evidence to support it. So we got to get over this body weight thing. And we have to demystify and demyth it. We have to be myth busters. And we have to say things like diabetes is a serious risk factor. Treating diabetics with statins is an important way to prevent heart disease. Number two is get heart checked. We have these new scores. They are on smartphones. They're going to be available in Rite Aid, Save-On, and Costco. There's just no reason somebody shouldn't know what the risk is for heart disease. Advocacy, we spend 10 times more NIH and NGO dollars on breast cancer, yet cardiovascular disease spends 10 times more on women, and this is another gender issue. Women own their breast, and the medical establishment is very happy to define women by their breasts. They like looking at them, they like touching them. The American Heart Association spends less than 4% of their Go Red proceeds. This is their biggest fundraiser ever on women's cardiovascular disease research. So we really have to get going with this advocacy. All right, here, finally are my survey results, and these have, I think, implications. I pulled out the slides that I thought you would want to hear about as medical curriculum educators. So the purpose of this survey, and this was a nationally commissioned physician survey done by the group that does surveys, polling for presidential campaigns. So we spent a lot of money and they did a good job. We wanted to quantitatively test several hypotheses. They're listed there. It was a survey among 199 primary care physicians and 100 cardiologists. The primary care was internists, family practice, GPs, and OBGYN. They had to be practicing at least 3 years. They had to see a substantial number of female patients. Among primary care physicians, heart disease is a second-tier concern after weight issues and breast health. So exactly what we thought. And this is an extreme gendered issue. And somehow we're going to have to work on this. We cannot continue to define women by their breasts, and when we don't like the way they look because they don't look like the models on Cosmopolitan, we cannot tell them that they're overweight. Okay. Blue is primary care, red is cardiologist. When asked about how well their medical school training prepared them to assess female patients' risk of heart disease, both doctor groups revealed significant room for improvement. And this is your call. They said, we don't know enough about this. And these are doctors in practice. We've done similar. We're going to hear from MJ about a national survey. We've done a local survey. Overwhelmingly, our residents, interns, residents, and fellows said they don't know enough, and they'd like to know more. More primary care physicians than cardiologists note that women's heart health does not get enough attention in medical resources. Although nearly all agree that women can present differently with heart disease than men, far fewer agree that a woman's heart is different than a man's. So this is, despite 20 plus years of research, we still have docs in practice that say, no, don't think it's different. And, I'm like, I'm sorry, I guess I'm confusing you with the facts. It's, have you read the journals lately? And that's going to be a tough nut to crack, and maybe all we can do is get the youngsters straightened out. And when the young up and coming, that's what's so good about teaching hospitals, that they keep the older doctors honest. Although primary care physicians' interest in campaign activities was predominantly soft, so primary care docs said pretty much, we don't have a lot of time to be worried about this sex and gender stuff. Large percentages wanted to learn more about gender differences and discuss the heart check. So it's kind of mixed messages, but I think that that means that there is room. And then here's where I think the room is going to be. The social media savvy doctors express more interest in learning about gender differences in heart disease than their counterparts. And we've done this with our electronic health record. When it was deployed in our medical center 4 years ago, we had about 20% of the real old guys, they just retired. They just, that's it, you know. And so I think, you know, what we're going to have to do is hope that these younger physicians are going to be media savvy, and this is going to be a way that we can help to educate them. Physicians continue to rely mostly on printed information. Growing numbers utilize email, search engines, and medical information sites, but only a few use social media to communicate with their patients or review health-related information. I think that will change with the electronic health record. It certainly has changed with us, where we now can do remote monitoring for blood pressure, heart rate, etc., using the smartphones. Epic is the leading electronic health record. And, you know, all of the young physicians now, I mean, when they come to clinic with me and they're rotating, they're like, oh, you have Epic? Oh, we don't have to write notes. All right, so, well, it's almost like they don't know how to write anymore, too. They come to clinic and they don't have a pen. And you're like, how can you come to clinic without a pen? They don't have a pen. All right, so that's our website. Those are our data, and my time is up, so I'm happy to get off the stage or take questions. Thanks.